week, and also a reminder to please remember to turn back in the audience response cards here at the end of the program. Today, it's my pleasure to introduce Dr. Nitin Pagedar. Dr. Pagedar is assistant professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Iowa, and he's also director of the Division of Head and Neck Oncology at the University of Iowa. Dr. Pagedar has been extensively published in the peer-reviewed literature. He's authored several textbook chapters, and he's currently a reviewer for the journals Head and Neck, the JAMA Otolaryngology, and Laryngoscope, and he has kindly accepted the invitation from the CME committee to drive over from Iowa City today to update us on what's new in otolaryngology in 2014. And please join me in welcoming Dr. Pagedar.
Thank you, Dr. Hallberg. Can you all hear me okay? Great. Good afternoon. It's really a pleasure for me to have made the short trip from Iowa City to be here with you today. And so my focus was going to be on trying to describe to you what's new in otolaryngology. And so thinking about this, I don't often get a chance to think so broadly about my specialty as a whole. And so I tried to make a list here of the kinds of things that are at the forefront of our field right now. We think about human papillomavirus and the changing face of head and neck cancer. We think about the use of botulinum toxin in the otolaryngology clinic as sort of an exploding field in which new indications are being discovered. There are even less invasive types of sinus surgery. We have advances in hearing loss diagnostics and hearing loss treatments, surgical and otherwise. The phenomenon of sublingual allergy immunotherapy has come up in our specialty strongly, and in other specialties, no doubt. And then we've got advances in sleep apnea surgery as a condition that's fairly common and for which standard treatments haven't been as successful as anyone wants them to. And so when I coming up with those things, what I decided was that would probably be a lot to talk about in the time we have allotted here today. And so those four we can think about covering some other time, and I'm going to spend the time we have today talking about those first two things. So, starting with the changing face of head and neck cancer. So here is a chart that shows the incidence of cancer at all sites in the United States. And this comes from the SEER database run by the National Cancer Institute. And if you look at cancer incidence between 1973 and 2010, here is what we're looking at. So there was a peak in the early 1990s from where we started in the 70s. And since then, between 1990 and 2010, there's a general trend towards lower and lower incidence rates. So the question for you as we start this is, what's the recent incidence trend for head and neck cancer? So I think you all have audience response devices. Looks like we're getting some answers, so I'll give you a few more seconds. Okay, so we've got some votes for increasing, not fewer votes for decreasing, and about half people suggesting it's complicated. And so I'll go through some data to show you that. Actually, my first slide is going to cover that pretty nicely. So yeah, I would agree with the it's complicated definition. So the blue line at the top represents cancers of the oral cavity, so of the mouth, the tongue, the cheeks, the lips, the floor of mouth, the retromolar trigone, and the palate. And so you can see that since 1973, there's a pretty clear trend towards decreasing incidence rates. And if you can almost see that, it's almost only 50% of what it was in 1973. The green line below that is for the larynx. And so the larynx cancers may be a little bit more strongly associated with tobacco use. There's been a well-described peak of tobacco use several decades ago. And so with the time delay related to cancer incidence and carcinogenesis from tobacco, we're seeing the same trend with larynx cancer, that we're seeing many fewer of them than we used to be. But if we break out the tonsil and the base of tongue, apart from that, we are seeing that almost the opposite trend, where the incidence is almost double in 2010 what it was in 1973. And this is a big deal, and it's impacting a lot about how me and people like me in the head and neck cancer world see our average patient. So what's the difference? Well, human papillomavirus, and I'm sure you've heard a lot about that. We'll talk about human papillomavirus as it associates with head and neck cancer. And so specifically, it's not head and neck cancer in general, but it is very specifically oropharynx cancer. And within the oropharynx, it's really the the tonsils, and the tongue base. The links between those sites and human papillomavirus were really first identified back in the 1990s, so really not that long ago. This disease is more common in men. We are not talking about cancers in the oral cavity, the larynx, or the nasopharynx. And the studies are showing us that by 2020, human papillomavirus-related oropharynx cancer is actually going to be more common than cancer of the uterine cervix. And so we think about HPV and cervical cancer as the sort of a tight association in the minds of clinicians, but in fact, before too much longer, HPV is going to be more strongly associated with oropharynx cancer than cervical cancer. And so this chart that I'm showing on the right side of the screen there shows the proportion of oropharynx cancers that are thought to be related to human papillomavirus. And so back in that period on the left side of that chart from 1984 to 1989, there were only about 20% of cancers of the oropharynx were associated with HPV. But looking at more recent specimens, this is based on a study of tissue, an archived tissue, from the more recent era, from 2000 to 2004, at the right side of that chart, almost 75% of oropharynx cancers are HPV related in the modern era. So this is a big difference compared to even some of the textbooks that I have on my shelf. So human papillomavirus, we heard about in lots of different circumstances, as we mentioned already. It's a DNA virus. It relates to warts that we see in the skin. It relates to laryngeal papillomas. It relates to anogenital tract cancers, mainly of the uterine cervix. And when we see that, it's HPV type 16 and 18, or the bad actors in terms of cancer. It is the most common sexually transmitted infection that we see. So why does HPV matter to us in the otolaryngology clinic or the head and neck cancer clinic? So as we've talked about already, HPV cancer is common. And not only that, it is actually getting more common. So we're seeing a lot of it, and we're only going to see more of it as time goes on. So the questions that we should have as clinicians is, does it behave differently? And should we treat these patients differently? And so those are the things that I'll address here next. So it turns out that HPV-related oropharynx cancer behaves differently. It is practically a different disease than the classic HPV-negative oropharynx cancers that we saw in patients that were heavy users of tobacco and alcohol. More specifically, these patients are younger, so the average age at diagnosis is about 10 years earlier than the 65 years in which we see classic head and neck cancer patients who are smokers and drinkers. Age under 50 is actually pretty common for some of these cancers. These patients come in with fewer comorbidities. Again, they are not heavy drinkers, they are not smokers, and so they are healthier, apart from their cancers, when they come in for their initial evaluation. These patients present with advanced neck metastases in general. Most of the time, these patients present with multiple nodes in the neck, and that automatically makes them stage 4. It is actually uncommon for us to see an oropharynx cancer patient that is earlier than stage 4. Sometimes we see stage 3. We very rarely see stage 1 or stage 2. And the primary tumor is often asymptomatic, and that sort of ties in with that patients present for evaluation of neck masses, and automatically that makes them present when they're identified as having had cancer, they're automatically come as stage 4s. So what happens to these patients? Well, we actually see improved survival, and it is fairly substantially improved. The difference is enormous. So even though these patients come at advanced stage, their likelihood of surviving 5 years after their cancer diagnosis is outstanding. And so the graph that I'm showing there is an observed survival curve from a randomized study that was done for another reason. However, that study also happened to look at HPV as one of the covariates, and so they actually just showed survival, not based on the treatment assignment in that study, but survival based on HPV status. And what I'm showing here, as you can see, the chart shows something called P16 positive. So P16 is the test we use to mark as a marker for HPV. So P16 positive means HPV positive. And the difference is huge. The 5-year survival in these patients, which are stage 3 and stage 4 patients, is almost 80% in that study, as opposed to what we'd expect, those patients that are P16 negative, under 50% survival for these stage 3 and 4 patients over a 5-year period. One of the things that this study showed us, published in 2010, was that tobacco use decreases the survival advantage. So if you look at the same chart only in smokers, the difference is much smaller, and the benefit of HPV in cancer outcomes is much less in people that are smokers. So I'm going to go right from there to issues about prevention. What's the scope of this problem? Do we see HPV? We know about HPV as the cause of cervical cancer. What can we do? What's the scope of the problem in the oropharynx? So this was a study that was done as part of a National Health and Nutrition Evaluation Survey, the NHANES study, that is done every year, sponsored by CDC. And in 2012, a paper was published in which HPV was studied as part of that NHANES study, in which surveyors go out to study randomized selection of the population in order to understand people's health. And so in that study, they had people do oral swabs or oral rinses, and HPV DNA was evaluated in those patients. And so it turns out that if you look at a cross-section of the U.S. population, about 7% of patients have identifiable HPV DNA in their oropharynx, or on those swabs or rinses. And that's actually substantially different between men and women. It's 10% of men, 3.6% of women. If you look at HPV-16, which is, again, one of those bad actors and the one that's responsible for the vast majority of cancers, both in the uterine cervix as well as in the oropharynx, fully 1% of patients. Again, this is not cancer patients, but these are a randomized selection of the U.S. population. 1% had HPV-16 identifiable in the oral rinse. So this is a highly prevalent virus. And so the question is, why sometimes does it cause cancer, and many times does it not? This is the question that people are working on as we speak, and I think there's a lot about that we don't quite understand. Again, this field of study is 10 years old at most, and so there's a lot of questions that we have and we don't have answers yet. In that study, sexual behaviors were strong risk factors for HPV positivity in the pharynx. And importantly, non-sexual contact risk factors were not associated with HPV positivity. Interestingly enough, tobacco use was a risk factor. And so smokers were more likely to have HPV in the pharynx, on the rinse or the swab. And as we have already heard, the outcomes for cancer are actually worse in smokers. So the interaction between tobacco and HPV in cancer patients is actually quite complicated. And I think that's one of the issues about which I think the story hasn't been completely told. So moving on, prevention, we know one of the primary issues that we have for HPV is a vaccine. And this is something we didn't have even 10 years ago. There are 2 vaccines that were tested on the basis of their effect on cervical cancer and cervical dysplasia in women. One of them is a quadrivalent vaccine against type 6, 11, 16, and 18. And the other is a bivalent vaccine against only type 16 and 18. Again, those are the ones that cause all the cancers. The vaccine is available. Typically, both of these things are given and recommended as a 3-dose series over 6 months. In 2007, the U.S. recommendation, since 2007, the U.S. recommendation has been for routine immunization of girls starting between age 11 and 12, and can be given starting at up to about age 26 for women that have not already had the vaccine or not already had the series. So the next question I have for you all, is the HPV vaccine recommended for boys? We'll go a simple yes, no. We'll just take a couple minutes more, or a couple seconds more. We'll stop there. So we've got 63% voting yes and 38% voting no. So it turns out that in 2011, the Committee on Immunization Practices has recommended that boys start the vaccine series at about age 11 or 12, the same studies, the same ages as for girls. This was based on studies of genital warts in men, and so we know that the risk of that and the risk of penile cancer that follows that is lower for boys that have received the vaccine. And so that's why the quadrivalent vaccine was studied and is now recommended for boys. It can be given starting at age up to 21, and for men with HIV or other immunocompromised status, it can be started up to age 26, and those are within recommendations. And so the question is, does it work? You know, that the study that I described to you that was published in 2012 using the oral rinse and the oral swabs didn't study men specifically, but they described that in the 290 vaccinated women that happened to show up in that cross-sectional study, 0% of them had HPV in the pharynx. And so as far as we can tell, the vaccine is effective at preventing oropharyngeal carriage. And what we hope then is to extrapolate that to say that HPV vaccines will be effective at preventing oropharynx cancer, but those studies have not been done yet. No doubt they're underway, but I think the data is not mature enough for us to know the answer to that question yet. What we know about the vaccine is that the proportion of girls actually completing this vaccine is not as great as we would like it to be, although it seems to have improved over the last couple of years. So what we know as of 2014, the most recent data suggests that 57% of girls have had at least one dose, and that, as we might imagine, girls with less access to health care and those that are poor, a minority status, and uninsured are less likely to complete the entire series. We have less data about boys, but we know that only 36% of boys, of eligible boys as of 2014, had at least one dose. How do we test for HPV when we're thinking about oropharynx cancer? So that testing is performed on a biopsy specimen. We don't use serum tests, so we don't use serum antibody tests. We don't use the high-risk HPV test that can be used for the uterine cervix during a cytologic exam. But those tests are not thought to be useful, or at least haven't been studied in the oropharynx. So really, we know if the cancer is HPV-related by testing the actual biopsy tissue. And as I mentioned several slides ago, we test for something called P16. So HPV E7 is one of the proteins produced by the HPV virus after infection, and that results in a cascade of events that results in us finding a protein in the cell called P16, for which we have a reliable and inexpensive immunohistochemical test that we can apply easily on a biopsy specimen. We can sometimes do it on a cytology specimen, on a needle biopsy of a lymph node, but typically the most reliable testing is done on an actual piece of tissue on which immunohistochemistry can be performed. The standard treatment for cancers of the pharynx is chemotherapy and radiation. And that's a fairly standard treatment that was introduced in the late 1990s and probably what most patients end up getting. And this is 3 cycles of cisplatin, 35 radiation treatments. We expect good outcomes, especially in these patients with HPV-related cancer. Again, from our randomized trial, which is not that different from what I would expect on the basis of my thoughts about patients that have come into my own clinic, 80 to 90% 5-year survival is, we expect these patients to do well. We expect these patients who come in younger and without comorbidities to have an easier course with treatment. Their risk of toxicities during treatment is a little bit less. They return to work. They return to their functional status. They return to swallowing. Pretty much everything you can think about these patients is better than patients who are HPV negative with otherwise the same cancer. So this is really a different disease. However, there are risks to chemotherapy and radiation that come to these patients as well, just like for patients that had HPV negative cancers. These are xerostomia, fibrosis, osteoradionecrosis, a destructive condition of the mandible, given that these cancers are actually quite close to the bone, and so it's impossible to completely eliminate radiation dose to the mandible during treatment of the base of tongue and the rest of the oropharynx. And then, we think about things like radiation-induced second primary. We think about the cost of a 7-week course of treatment. These are substantial issues to think about. So, this is a typical patient who's just finishing the course of 7 weeks, 35 radiation treatments, 3 cycles of cisplatin. You can see the neck looks as desquamated. It looks like a sunburn, and when the patient opens his mouth, it actually looks like the same thing on the inside. It looks pretty terrible. Patients are uncomfortable. This is the difficult thing to send patients through. And so the question is this the right thing? So, we get the good outcomes that we want, but the question is, do we have an alternative? So here's what standard surgery would look like. If that same patient came in with a cancer of the pharynx, here's what classic surgery would entail. We can't really see the cancer very well in the back of the tongue just by having the patient open their mouth, and so we need to make a wider exposure. And so we end up making this kind of incision from the neck, through the chin, through the lip. You couldn't invite a surgeon to give a talk without expecting a picture that looks like this. So here we have cut the mandible right there after bending some titanium plates before we cut the bone, so that way we can put it back the way it came from. We're not removing any bone. We just need to cut it in order to get access to the stuff that's behind it. And so we've cut the bone. We've made a wider exposure. This is the lingual nerve that we've put on stretch here coming into the tongue. And so now what we're starting to see is this cancer that involves the tonsil, the tongue base, and the soft palate right over there. As we are getting wider and wider exposure, and eventually, looking from the front, this patient looks like that. So we've cut through and through the soft palate, we've removed the tonsil, we've removed a portion of the tongue base. This yellow thing is a feeding tube in the back of the throat. And then eventually we need to reconstruct this, typically using tissue from the skin of the thigh or the forearm, in a complicated procedure that typically lasts 10 to 12 hours. The patient's in the hospital for a week. Eventually we expect them to have some return of function, but clearly this is not something that is going to be easy to recover from. If we told patients that this was their only option, many people would choose it. But the question is, do we have something better? I don't think this is better than 35 radiation treatments, but what other options do we have? So it turns out that in the head and neck field, one of the most exciting new developments is the advent of this new surgical instrument, new surgical technique. So we've got the Android, we've got HAL, we've got R2-D2. What you might see coming here is that we've got a robot that can do that. So this is called the Da Vinci robot. It is a surgical system that has been used in gynecology, urology, colorectal surgery, cardiac and thoracic surgery, and since 2010, head and neck. And this has the promise to revolutionize the kinds of operations we can do and the kinds of morbidity we can spare patients. And so it looks a little bit like this when we're in the middle of a case. So here is the sort of a general overview of the operating room. This is the patient. Here's the robot. If you look at it more of a schematic way, here's the control panel, the console for the robot. Here's the surgeon who is sitting somewhat away from the patient, controlling the robot with his hands right there, with some feet controls as well. Here's the surgical assistant who's at the head of the bed, assisting the surgeon with exposure or whatever else needs to be done over there. Here is the robot that's in position over the patient, poised to do what the surgeon's telling it to do. Here is the view from the robot. So this is what the surgeon sees. It's actually a binocular view. It's a three-dimensional view that the surgeon gets looking in that console right there. And there are these instruments that are extending. They're small instruments that are grasping and can use cautery. There are instruments that use lasers. There are all kinds of things we can put through those instruments. And importantly, those instruments have wrists. And so those wrists are inside the patient. So these are basically miniaturized arms that can fit inside the patient. We get a nice three-dimensional view inside the patient, and we can manipulate those tissues sort of working around the corner. And that's what we couldn't do with standard traditional surgery, and that's why I had to cut a jawbone to get access to the tongue base, but now we can sort of stick the instruments through the open mouth and prevent a lot of the morbidity that comes just from exposing the cancer. And so it gives us access that we never really had before to the tongue base and the tonsil. It provides us with visualization, hemostasis. Obviously, as a surgeon, if you can't see what you're doing, either whether it's around a corner or whether there's blood in the way, you can't make much progress. It allows you to manipulate tissue like you would if you had, an easy view of it. And the idea is that because we have easier access, we don't have to manipulate so much just to get to the cancer. We therefore don't have to reconstruct all those things on the way back out at the end of the operation. We can leave the patient with improved sensation in the pharynx and the larynx, and therefore improved swallowing. And so, the first three of those things are what allows us to get negative margins. That's the whole point of surgical oncology. We go in there, take something out, get a little bit of normal all the way around it, and get the negative margins we need to get this patient on to the next phase of their treatment. And improved sensation and swallowing means that we can get those margins while preserving function for these patients. And so as I mentioned before, this particular instrument applied to this particular problem received FDA approval a few years ago. And so it's sort of spreading in its applications. And so the new paradigm is, whereas before, for patients with advanced stage cancer of the oropharynx, we were sending through radiation and chemotherapy. The issue now is whether we can, instead of giving them chemotherapy, we might have the option of doing an operation to remove the cancer and then giving them adjuvant radiotherapy. And so we're trading chemotherapy for surgery, and that might be, ultimately it is the question now is whether that's a good trade-off, and the only way to answer that is with a trial that will hopefully allow us to answer that question. So studies are ongoing. There is an ECOG study, which is a multi-center nationwide study. in which patients are accrued. Now, it doesn't specifically answer the question about surgery versus chemotherapy. It allows us to establish surgery as a reasonable thing to do. And so here's the schema of the study, that patients end up getting endoscopic surgery, like with the robot. They then, based on the factors identified at the time of surgery, have a risk assessment. Either they're high risk, they're intermediate risk, or they're low risk, based on the tumor factors, the node factors, and other factors that come out on the basis of the pathology report. For patients that are high risk, we give them standard adjuvant treatment with chemo and radiation. For patients that are low risk, this is a new thing. For patients with small cancers, no positive nodes or only one small positive node, and otherwise satisfactory margins, we don't give them adjuvant therapy. And for patients with intermediate risk that have some of the factors but not all the factors, those patients are being randomized to receiving standard adjuvant radiation versus a de-intensified adjuvant radiation, so radiation that might spare some of those side effects, some of that sunburn effect and fibrosis and risk of osteoradionecrosis that our standard therapy provides. And this is being done in patients that specifically have HPV-positive tumors, because we're expecting those patients to respond better. So the question is, we want the same response with fewer side effects, and so can we do this on the basis of using robotic surgery? And this is a study that's just getting up to speed now. There are more and more centers ongoing. Our approval to participate in the study at the University of Iowa is hopefully just a few weeks or months away, and we hope to be able to recruit patients to the study in the near future. So, in summary, HPV-related oropharynx cancer is a new disease. We think about this as a completely different thing than the standard oropharynx cancer that we saw even 5-10 years ago. And this is now literally about 75% of the oropharynx cancers that we see. This is common in my clinic, and it's only going to be more common in the future as far as we can tell. So the patient characteristics are different, the oncologic outcomes are different, and the functional outcomes are different. It responds better to standard treatment. And so the question that we have now is, can we get the same cancer outcomes with better long-term functional outcomes? And that's what's under study right now. So I'm going to move on to the other topic I wanted to cover, and that is the expanding repertoire of botulinum toxin in the otolaryngology clinic. This is a fascinating field, and it seems like the more literature you look at, the more interesting things you find. So we'll go over with botulinum toxin how it works and the kinds of things it's used for. We'll talk about facial rejuvenation. It's something that you've probably already heard about before. And then issues about, therapeutic issues related to facial paralysis. And then some interesting things that were being done in our clinics related to laryngeal and salivary gland disorders. So here's the next question for the group. Where does botulinum toxin act? Does it act at the central nervous system, at the dorsal root ganglia, the peripheral nerve axon, or the neuromuscular junction? Take about 10 seconds to answer the question here. All right, so let's see what the group said. Looks like 64% said neuromuscular junction. We've got a smattering of suggestions about other areas. So let's go through let's talk about the mechanism just a little bit, because it illustrates a lot about how else we might be able to use this medication. So at the bottom of the screen there, I've shown an axon, a dendrite of another cell, and in between the junction between the two, so the synaptic cleft. And so that little box is what's blown up in this area right here. So we've got synaptic vesicles in the axon that contain the neurotransmitter acetylcholine. And there are a variety of factors that allow, and these are the colored lines here, these are proteins in the axon that interact with the synaptic vesicle and the synaptic cleft that ultimately result in the exocytosis of the acetylcholine into that synaptic cleft, and then therefore downstream effects of that neuromuscular transmission. And so what are shown in these arrows are the areas at which we have pharmacologic inhibition of this process. And so what we are seeing here basically is the BONT is the botulinum neurotoxin, and these are the areas in which these can take physiologic effect. And so it turns out that this works at any cholinergic neuroeffector junction. So skeletal muscle is the vast majority of these junctions, but it turns out there are some others like parasympathetics that we'll get into in a few minutes. we've got pharmacologic agents available on the market that affect the botulinum neurotoxin A and botulinum neurotoxin B targets, and all of these things shut down this neuromuscular transmission. Over a period of time, the cell, just like any other cell, will carry out protein synthesis and regenerate some of these effector molecules so that the effect of these neurotoxins dissipates over time. Typically, that's 3 to 6 months over that time. So during that time, you will have basically a shutdown of neurotransmission at that effector junction, and over a period of time, there's going to be natural recovery of function. So let's see what that can do for us. So facial rejuvenation. This is the means for which botulinum neurotoxins are typically have received FDA approval over the last some number of years. And so as you can see here, what's ultimately being demonstrated here are the vertical lines at the glabella. The glabella is this part of the central lower forehead right there in between the eyebrows. And so when this patient frowns, you can see fairly prominent horizontal lines up here and vertical lines down here. And so with application of botulinum neurotoxin, you can see resolution of those lines and an improvement in the patient's perception of their aesthetic appearance. There is another commonly used treatment, which is the horizontal lines that come out from the lateral canthus or the lateral eyelid area, sometimes called crow's feet. And these are a function of the lateral portion of the orbicularis oculi muscle, which is immediately subcutaneous in its position. And so superficial injections of the botulinum neurotoxin in that area can result in, again, the patient's perception of improved appearance of that particular symptom. And this is a fairly well-described phenomenon. This has been offered by dermatologists, facial plastic surgeons for many years now, and it seems to work pretty well. So it turns out that we can take advantage of those temporary paralyses for therapeutic purposes as well. So we have patients, you no doubt have seen patients with strokes or diagnoses of Bell's palsy or Ramsay-Hunt syndrome, other reasons to have unilateral facial weakness. And so as you can see here, when this patient smiles, the one side moves, the other side does not. And obviously this can be a source of a tremendously altered appearance for this patient that can be very distressing at times. Here's a younger woman that has the same phenomenon, whereby when she smiles, her mouth looks quite different. It's quite obvious, and maybe at rest she looks pretty natural, but when she smiles, it's very obvious that there's something going on with the left side of her face. And so it turns out that for many of these patients, you can actually weaken the normal side to restore the appearance of symmetry. And ultimately, many patients are quite satisfied with that appearance, especially if their facial paralysis is temporary. This temporary fix can be quite life-altering for many of these patients. So synkinesis is another issue. So when we've got patients with Bell's palsy or some sort of injury of the entire facial nerve that's going to recover, like many times Bell's palsy does, there can be a phenomenon of aberrant nerve regeneration. So fibers that used to extend to the forehead now extend down to the eyelid. Fibers that used to extend to the midface now extend to the lower face. And so when patients try to smile without squinting, they get an abnormal sort of mass movement of all of the muscles of the face. And they can find that debilitating or unpleasant. And so here's a patient, as you can see, she had a Bell's palsy on the left side. And when she smiles, you can see that there is some movement of the left side of the corner of the mouth, but fairly prominent movement, tensing of the platysma muscle in the upper neck. And patients can find this unpleasant or unaesthetic. And so botulinum, you can see here that she's making an effort to smile, and unfortunately the wrong muscles are moving along with the right muscles. And so botulinum toxin injection down to that platysma can restore symmetry. And even though the corner of her mouth isn't any better with smiling here, her neck is not quite as prominent afterwards as well. So this can be something that again can help patients with a debilitating or troubling symptom that they have. So then the question should arise, can this work with any muscle? We know that we can use it on muscles of facial expression. What about other muscles? So in the larynx, it turns out that we've got abductors and adductor muscles that control the position of the vocal cords. So this, on the left side of the screen there, is an endoscopic view of a functional larynx with the left vocal cord a little bit obscured by the upper larynx, but the right vocal cord well in view right here. And so it turns out that If you look at the larynx without the lining tissue, without the mucosa, behind the larynx, so sort of in that area back there, there's a muscle that attaches to what's called the arytenoid cartilage, and that controls the abduction of the larynx. And so contraction of the posterior cricoarytenoid muscle will result in abduction of the vocal cord. Turns out we also have adductor muscles in the larynx as well. And so there are a variety of muscles that sit in the paraglottic space, sort of underneath the mucosa right in that area. The main one is called the thyroarytenoid muscle, and so it turns out that contraction of that thyroarytenoid muscle will have the opposite effect. It will spin the arytenoid so that the vocal cord gets adducted, or comes towards the middle. And so it turns out that these are targets for botulinum toxin as well in very specific circumstances. So what I'm going to show you here is a video that is available on my department's website, the Iowa Head and Neck Protocols, for the effect of this treatment on a patient with a laryngeal tremor. So I'm going to start this video here.
Can you tell?
Today is
I'm going to start it right about there or so.
13, 2012.
And how's your voice going?
My voice is in bad shape today.
So that is the sound and the voice of a patient with a laryngeal tremor or a vocal tremor. This is complicated, like any other tremor, a complicated neurologic disorder. In her case, it's not spasmodic dysphonia. It's not associated with other neuromuscular problems or other neurologic issues. It's specifically an intention tremor related to the voice. And the other voice you heard on that recording was my colleague, Dr. Hoffman, who has kindly provided a sort of an after treatment picture of what her voice can sound like. So I'm going to come out to about here or so.
Great.
But
We'll go right about there. So this is after injection.
well, they evolved from not being able to talk on the phone to, well, I would think that perhaps I would need my injection a little earlier. I let it go 5, almost 6 months.
So you can hear in her voice after injection, she's a little bit breathy. She doesn't have a strong voice. No doubt if she tried to reach the back row of this room without, she would have trouble making her voice heard. Air is escaping because she can't adduct her vocal cords completely because we've paralyzed some of those muscles. However, overall, I'm sure you would agree with me that her overall function is substantially better than before her botulinum toxin treatment. Let me go back to the slideshow. Whoops. Okay, so that kind of injection is typically done in the office under a local anesthetic. And so the question is, inside the larynx, how do you know, or how do we know that the needle is going to the right muscle? So it turns out that we can use electromyography to do that. So under a local anesthetic, or sometimes without even a local anesthetic, a needle can be passed through the anterior neck skin, through the cricothyroid membrane, and into the endolarynx. And we know if that needle is a monopolar electromyography needle, that we can identify the difference between adductor muscles and abductor muscles, because the adductors will function when the patient phonates. When the patient says E, you'll see a spike in the activity of that muscle, and when the patient takes a deep breath, you will see spikes in the abductor muscle activity. And so you can use those EMG signals to direct the needle and verify that you're injecting the muscle that you're trying to inject, and can have the effect that we just saw in those videos right there. Now, just to be clear about this is not an FDA-approved use of botulinum toxin, but it is one that is quite common in the Office of Professional Laryngologists. It can be used for dysphagia as well. So this is fluoroscopy image is a patient who's had a total laryngectomy, who has this finding of what's called a cricopharyngeal bar. And so as you can look right over there, there's an impression made on the barium column of a muscle that is hypertrophic, and this is the cricopharyngeus that has, for one reason or another, become quite large and quite prominent. And this muscle doesn't relax very well in order to allow food boluses to pass through it. And so it functionally narrows the esophageal inlet, and this also is a target for botulinum neurotoxin, which will relieve symptoms for what we expect to be about 3 months. And this is an injection that we would do endoscopically, typically. So the question is, we've got skeletal muscles in the larynx, in the pharynx, in the face that could work. that could benefit from treatment therapeutically with botulinum neurotoxin. So the question is, could this work on just any neuroeffector junction? So let me talk a little bit about salivary gland physiology as it relates to salivary gland surgery. So this is an axial CT scan through the parotid gland. That's depicted in red right there. Overlying the parotid gland, of course, is the skin, and I'll get back to why that's important in a second. So in front of the parotid gland is the masseter muscle, and then there's the mandible sitting right next to it. And so during a parotid operation, well, I should say before we get there, there are parasympathetics that allow the parotid gland to function. The parasympathetics in the parotid would make it produce saliva and then push that saliva out of the gland into the oral cavity. And so while we're doing a parotid operation, we lift the skin up, we take out a portion of parotid, and we set the skin back down. But the parasympathetic supply remains into that parotid gland, and during eating, the parasympathetics will make the parotid produce saliva. But since we have manipulated the skin and the surface of the parotid gland, we've got skin that sits right up against the salivary tissue of the parotid. And that's not physiologic, that's not how we're all built. This is an alteration from parotid surgery. So it turns out that although there are no parasympathetics in your skin, there is still an effect that we'll see here with this diagram right over here. So if you remember back to the days in which we discussed the autonomic nervous system, there's sympathetic and parasympathetic. On the right side here, the parasympathetics supply the salivary glands, as we've seen, and those are cholinergic neurotransmitters that are in that area. Now, the sympathetic side, that's the fight or flight side, supplies the viscera and the vasculature in the head and neck and everywhere else for that matter, and those are adrenergic. Norepinephrine is the typical neurotransmitter in those axons and neuroeffector junctions. However, the exception of that is the sweat glands. So the sweat glands have cholinergic neurotransmission that is supplied from the sympathetic nervous system. So if we go back to that image, we've got skin and the sweat glands in the skin that are sitting right next to the parasympathetic nerve terminals from the cut edge of the parotid that we created at our parotid surgery. So there is a phenomenon called Fry syndrome, also known as gustatory sweating, which can affect up to about 50% of patients after parotidectomy. Depending on how closely you're looking for this, you will find it. So it turns out that what patients describe to us is that when they sit down to a meal and they smell their food, or they're just about ready to take their first bite, they notice a sensation of moisture on their skin, and what's happening is that it's sweat. And they're sweating during a meal, and most of the time patients tell us about this and they say, well, it happens, not a big deal. Some patients are really disturbed by this. Sometimes it can be a lot of sweating, and it can be a difficult experience to go to a restaurant or sit down with friends and have your face be leaking sweat during a meal. And so the treatment for this, and so what I'm shown in that diagram right there is something called the starch iodine test, in which iodine is painted on the skin and allowed to dry, followed by a coating of starch, and then you have the patient eat something or smell something, and it provokes that response, and the iodine and the starch turn brown where there's moisture, and you can identify the specific parts of the skin that have this aberrant regeneration of parasympathetic nerves onto the sweat glands that allows them to sweat during times of eating. And so the treatment is denervation of the skin, at least autonomic denervation. So we don't really care about sensation, we really care about the autonomics. And so it turns out that since these are cholinergic nerve terminals, botulinum toxin works just as well as anything else. And so you actually inject it intradermally. There is, this has been described, even a large series from France described back in 1999, that consistently people obtain relief from this. One of the things to know about it is that the duration of action of botulinum toxin when targeting parasympathetics is actually longer than when we target motor neurons. And so 6 to 9 months is actually fairly typical, whereas 3 to 6 months, and really 3 months, is what we find for motor and muscle injections. And so what we find is that there's consistent relief. Over a period of time, patients might require another injection, but in general, they require fewer and fewer of them as they go on, and not many patients require indefinite injections for the rest of their lives. And so this can be a fairly powerful, fairly easy thing for a patient to do that can improve a symptom that can be very disturbing to them. And there's the injection right into the spot. So, sialorrhea, another complicated problem that is typically multifactorial to say the least. So in children, the most common cause of sialorrhea is cerebral palsy. In adults, it is most likely related to neurologic disorders, ALS and Parkinson's disease, the vast majority of reasons we see this. But not always, and sometimes it's idiopathic, and there are a variety of reasons that patients can find discomfort with this. This can be an issue. Again, it is about your functioning in society, your functioning around other people, that can be very disturbing to patients if this is an ongoing problem. So it turns out that unstimulated, all the time when we've got saliva in our mouths, most of that comes from the submandibular gland, only 30% comes from the parotid. But when you actually sit down for a meal, actually about 80% of your saliva comes from your parotid. So it turns out if we can inject the parotid with and basically create that autonomic denervation or parasympathetic denervation of the parotid gland itself, it will produce less saliva and actually make this sialorrhea symptom better. And so typically what's done is the parotid is injected first. If there is sufficient improvement in symptoms, that's all we have to do, potentially have to do it later. If there isn't sufficient improvement in symptoms, the submandibular gland can be injected as well. So here's a depiction of this. And so on the screen over here, you can see using an ultrasound to identify the submandibular gland right over there. And this is the botulinum toxin being injected into the gland. As you can see a close-up of the monitor right over there, you can see the needle, this sort of ground glass structure right over there on the ultrasound is the submandibular gland itself. And so the dose of botulinum toxin is delivered into the parenchyma of the salivary gland. Note that the muscles of facial expression are quite a bit more superficial. They're actually in the skin or just underneath the subcutaneous tissue. And so we're not at risk we're at fairly low risk of inducing a facial paralysis with this technique, especially you worry about that in the parotid. So that's why we use the ultrasound, to make sure that we're delivering the dose deep enough to avoid the facial muscles. So in summary, botulinum toxin stops cholinergic signaling. It's more than just working on the aesthetic or the muscles of the mimetic muscles of the face. It can really stop any kind of cholinergic neurotransmission, both motor, parasympathetic, and in the sweat glands. It has a temporary effect, longer for parasympathetics than for motor nerves. And it has multiple novel uses that are some of which or most of which are not FDA approved at this point, but are increasingly common, especially in the hands of otolaryngologists and facial plastic surgeons. It's not just a cosmetic drug. So those are the things I wanted to cover today. On that note, I wanted to make sure that I just wanted to thank you all for your attention, for inviting me to speak and be in front of you today. I'm happy to take any questions either in front of the group or afterwards if you have any. Thank you very much for your attention.
Here, I'll go ahead and start. On your vaccine, your HPV vaccine,
yes.
What is the efficacy of just one injection?
So some of the more recent studies have actually shown that there is more efficacy of a single injection than was originally thought. And so it turns out that the 57% of girls and 36% of boys that have only received one dose actually do seem to derive some amount of benefit. I don't think the studies that show that are not as robust as the studies that show the efficacy of the vaccine when given as a 3-dose series. But it turns out it is better than we were hoping. So it turns out that even a single dose will have an effect. I'm not sure I can put it into numbers. Okay. Oh. Well, yes, one more question, please.
Is there an increase in dysphagia or a decrease after you do the procedure for the
For sialorrhea? Those studies, again, there are, at this point, the literature is still at the level where there are multiple techniques and lots of series that have been reported that are all fairly small. So this is not, I wouldn't say that we've got a tried and true method and tried and true results. I think that there are some patients that do experience some amount of dry mouth, but it's actually fairly uncommon. We don't see dry mouth from the salivary gland injections, typically because there are so many minor salivary glands in the mouth and the pharynx that the actual amount of sort of moisture in the oral cavity is not altered tremendously. What is altered is the volume that gets produced during a meal. And typically, I haven't seen a lot of literature that suggests that people overall find things more difficult. I think people seem to overall suggest that their quality of life is improved, although I don't think the literature is mature in terms of long-term outcomes.
If I may ask one more question
Sure.
on your botulinum, is there a decreasing effect after so many injections or so much time?
There is. That's a fairly classic thing that we see actually most of the time after years of use. We see this in certain cases in which, for example, like the patient with the cricopharyngeal bar, for which we are injecting a muscle for dysphagia that needs to be done over a long period of time. We see this also with patients that have been injected for spasmodic dysphonia. There's a phenomenon called tachyphylaxis, and we do see that phenomenon with botulinum toxin, at least the commercial formulation. So sometimes it has been described to switch to the other formulation. You know, there are now 3 different drugs on the market for botulinum toxin A, and 1 drug on the market which is botulinum toxin B, and sometimes switching from one to the other can make a difference. But yes, we see that over a period of time, typically many years, that we see that a specific injection is less effective and you have to go higher on the number of units that are injected or switch to a new technique, a new medication. It's a good question. Great, thanks.